He's a 72-year gentleman who presented with a lesion, a nodular lesion, hyperpigmented nodular lesion over the lateral aspect of the nose, over the left side. So patient underwent wide local excision with frozen section and a nasolabial flap reconstruction, following which patient had the final histopath revealed a blue.
Anyway, let's stick to the first part of it. So, the patient had the lesion in the classical BCC area. So, what is the classical BCC area?
Sir, it is a line joining the own grain line, joining the angle of the mouth and inner.
So, basically, no, you can't have it here. Green line is from angle of the mouth to the tragus or to the mastoid. So, somewhere here. So, above this is the site for BCC, and the most common site is, of course, nasolabial fold. So, the patient had a lesion here. Aankh band kar lijiyega, please. Band kar liye. And our challenge was to resect it, and the histopathology was actually basal cell carcinoma.
Yes, sir.
Now, basal cell carcinoma is of various types: nodular, basonodular, ulcerative, melanotic, and louder. Palisading, that's a histological type. But grossly nodular, ulcerative, mixture of both, melanotic when its color is black. So you also have basosquamous. Basosquamous has the worst prognosis because that is likely to have a mixed behavior. Usually there are no lymph nodes involved. What is the reason for that?
Sir, it is not spread by lymphatics.
Why doesn't it spread by lymphatics? That was the question.
It is a locally invasive disease. It invades.
Which means just the same thing. So why? I've been asking the same question. They're just saying the same thing in a different way. That it is locally invasive, so it doesn't go to the lymph nodes. My question is why?
Because the lymphatics are blocked here, so it does not.
So the lymphatics get blocked early, and it's a lymphatics. I mean, the pattern is such. So the lymphatics get blocked or clogged earlier, and that leads to no lymphatic drainage. In fact, one of the factors that will support the diagnosis of basal cell carcinoma would be absence of lymph nodes, locally invasive tumor, and the term rodent's ulcer. What is the reason for that?
In basal cell carcinoma, it is going on straight downwards, other than a coring.
Have you seen a rodent's hole?
Yes, sir.
It's narrow at the top, broad at the base. They almost have a colony inside. It's applicable to rats.
Yes, sir.
Rodents are rats only, right? So, and Surat had lots of rats in one time. Finally, they got rid of plague. So, top is narrow, the base is wide. So, it disfigures. Therefore, it's important to know what is the depth of invasion. How deep is the basal cell carcinoma gone? Whether the bone is damaged, cartilage is damaged, because you need to. It is disfiguring. So the term is it is disfiguring and it can produce deformities. Otherwise, it doesn't metastasize. Treatment for basal cell carcinoma is primarily surgery, which is wide local excision with a margin which can be very narrow. Why do we keep a narrow margin? How can we get away with narrow margin? Why do we?
Because it is not invading laterally, it is invading down beneath.
So because there are critical structures underneath.
Mainly the vital structure, not underneath, close by. So places where you don't need a lot of margin are vital organs, eyelids, genitalia, close to the nose. Like if you take a wider margin, you are going to get ectropion here. Okay, and it can erode into the nose. It can disfigure. So we need to, therefore, we don't take a lot of margin. And what is that surgery called? Mohs Micrographic Surgery, MMS. And what is that? You make squares.
Squares are made of approx 1 mm also, and each square is sent for histopath, frozen section on the table itself. So if one comes out to be negative, then that is the point where it is stopped.
Absolutely correct. So it's almost like no tumor on the ink in breast that we follow. So we take those squares bit by bit by bit. And you know, it is when Mohs micrographic concept came, the surgeon was resecting and was seeing under the microscope. So it was the same person doing both the jobs. I'm sure that was happening much better and faster. So you are able to save as much as possible. That is Mohs micrographic surgery. Clear?
Yes, sir.
And at the end, you should understand, once the biopsy was done, we took it up for surgery. I think we have shared this before in my channel. We have just shown the surgery as the resection happens, or otherwise we'll tag it and we'll show it again. What was the concept in taking a margin? We made it a point that we don't go very close to the lower eyelid. We leave a margin of at least 2 to 3 centimeters between the lesion and the lower eyelid, so that we don't get ectropion. And now you can see the eyes are closing nicely. So when we went in resection, what is it that we do? Shilpi, you were both there in resection. So what was the concept that we followed? We went straight down to the bone. It's a depth which is more important, correct?
Yes, sir.
And the whole thing was taken out, sent for frozen, margins negative. We just left it there, no wider excision. And we didn't bother about 0.6 centimeters, 0.5 centimeters, which we do for the squamous cell carcinoma and other lesions. The other thing which was important was to make sure that you don't damage the nasolabial artery, which is a branch of facial artery. And actually we use Doppler to localize it, but I can feel it by putting my finger directly here. You all can feel it here on your own self. Anybody with a normal nasolabial fold will have a nasolabial artery there. Now nobody is going to say, I don't have it now. That's the only problem. If you don't feel it, don't say it. Can you feel it? Bring your thumb. Here. That's what we based it on. So we mobilized. This tissue was not here. This tissue was somewhere here. We moved it here. So it's kind of a axial flap. What is an axial flap?
Axial flap is based on an artery.
Known vessel.
Known vessels.
Random flap is on unknown vessels.
vessels.
So that can be transposition flap or whatever. The moment you know the vessel, it's an axial flap. Ideally, axial flap is more likely to survive rather than the
Random flap.
random flap. So we have a axial flap in the form of nasolabial flap, and it is healed very well. You can see that we have put monocryl sutures which are going to dissolve on their own. The eyes open up. आँख खोलिएगा please. पूरा बंद करिए. खोलिए, बंद करिए. दांत दिखाइए अपने. ऐसे जैसे हम कर रहे हैं. ऐसे. See, the nasolabial fold is not compromised either. So these are the muscles of facial expression which should stay. But functional should not happen. The other thing, which is the other thing I was constantly talking about when doing this surgery, that I need to take care of. Quickly.
Highlights, ectropion one, and second is cartilage of the.
Cartilage, yes. We did have to take out a part of it. What else? Nasolacrimal duct.
Yes, sir.
Nasolacrimal duct can get damaged and you may produce epiphora. Patient may have constant watering, but he doesn't have it. आपको थोड़ा रिकॉर्ड किया है और आपको कोई ऑब्जेक्शन तो नहीं है ना?
नहीं कोई
सबके पढ़ाने के काम आता है.
क्योंकि केएमसी में हमने देखा है.
हाँ.
वहाँ मैं MIT मणिपाल में था पूरा.
अच्छा आप एनाटॉमी में थे?
MIT मणिपाल में.
MIT में थे. Thank you. So this is meant for teaching. And thank you for
So they are
cooperating.
MD student or PhD student under you.
Oh, अच्छा. So they are students you met.
I'm talking about all three.
They are all, yes, they are all students, and they are going to become cancer surgeons. So they're slightly higher than MD, MS. They're beyond MS. Okay, so they are all qualified surgeons already. Now they're going to become cancer surgeons. So all very special people.
All the best to all of you.
Thank you. Now, adjuvant treatment. The margins are all clear. Now you can talk about the report that you were saying. No? You were referring to it. Read through it quickly without wasting a lot of time. We also had a nevus at the back, which we removed. Which nevus is more likely to be cancerous or likely to change into cancer?
So there are 5 characteristics which we should look for. If the nevus is asymmetric, the borders are irregular, and if the color is changing, there is asymmetry in the shape and size, and it is.
दो बार asymmetry हो गई. शाबाश. आगे
And
चलो.
the
So it is A, B, C. It is A, B, C, D, E. He had A, B, but C and D was not there. So A is asymmetry, B is borders, C color, D deformity, and E is expansion. So he didn't have any of those, but itching and sinks into the what my answer to my question was junctional nevus. It's a junctional nevi which tend to become cancerous. So this came out to be benign. So the nevus is fine, which we are ruling out because skin cancers happen together. There are predominantly 3 of them: malignant melanomas, squamous cell carcinoma, and basal cell carcinoma. So you need to exclude all 3. I mentioned to you about melanotic variety of basal cell carcinoma, BCC. So all that is covered in the same room. Is that okay? Now we have to plan on adjuvant treatment. What is the background? What is it that you would require? Can you read out quickly the
So
report?
it is a nodular and adenoid type of BCC, and tumor was involving more than half thickness of the reticular dermis. DOI was 2 to 3 mm. The perineural invasion was not present, and lymphovascular
Fine.
invasion was not present.
So now, what are the criteria for deciding on radiation in BCC?
If it is close to the vital structure, then we can't do.
No. Adjuvant surgery is done.
So if the depth of invasion is more, if there is margin is showing positivity. Third is
See, so all those are correct. PNI, presence of
lymphovascular invasion.
LVI, high grade, high risk. None of those characteristics are here, so he may not require radiation. If you don't put on radiation, you keep on very close surveillance, which is what we are going to do with him. And we'll watch it if it appears, but it won't. That is, the surgery alone is adequate in these cases. Radiation comes only in recurrent BCC, PNI positive, DOI being very high, say more than 10 millimeter, let's take it this way. And if you have the grade or the other factors, that is very low. In his case, it may not be required. And we are going to take care of this exercises. Everything is perfect. Coming to the cosmetic appearance, also it's going to become absolutely normal. You can remove all these sutures. Aad ekdam theek hai. Thank you for cooperating. You're a professor yourself, so I'm so glad. I'll take a shot.